Hello, and welcome to the Center for Health Design's Evidence-Based Journal Club. Thanks for joining us. I'm Alan Card, your host for today's session. As a bit of an introduction, I'm a research associate with the Center for Health Design, working on several special projects, including the development of the CHD Online Safety Risk Assessment Toolkit. And I also serve as the editor of the Journal of Healthcare Risk Management. I hold a PhD from the University of Cambridge and an MPH from the University of South Florida, as well as professional certifications in public health, healthcare quality, and healthcare risk management. My research interests focus on risk management, patient safety, and healthcare quality. Before we begin, I'd like to thank the HERD Journal for providing free access to the articles we typically review. If you've not already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 10% off the subscription. Special thanks to today's sponsors, Steelcase Health and American Ultraviolet. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes, and to apply that in the real world. I'm now excited to introduce you to the authors of the article we're discussing today, Khatara Hadi, Jennifer Dubose, and Erica Reichert. Khatara is a PhD student and a researcher in evidence-based design at the College of Design, Georgia Institute of Technology, and a design analyst at HDR working on data-driven design team. She's interested in creating better environments for patients, caregivers, and families through evidence-based design strategies, applied research, and simulation. She's been involved in major research projects about the impact of lighting on patients and caregiver health, wellness, satisfaction, and performance with industry partners such as Philips, Hillrom, Acuity Brands, and HDR. Jennifer is the Associate Director of the Simtegrate Design Lab and a Senior Research Associate at the College of Design at Georgia Tech. Her research focuses on evidence-based design for healthcare facilities projects. Ms. Dubose's work seeks to expand the functionality of tools such as simulation, observation, and mock-ups for understanding the impact of space on behavior and outcomes. She recently completed a large project evaluating variation in patient-centered medical homes, clinic design, care process, and outcomes for the military health system. She has authored numerous peer-reviewed articles and has been an invited speaker at national and international meetings. Dr. Reichert is an associate professor of architectural engineering at the University of Nebraska-Lincoln, where she specializes in engineering built environments that are conducive to healthy occupant outcomes. She's actively involved in research linking healthcare environment outcomes, e.g. acoustics, lighting, spatial layout, to patient and staff outcomes. This includes research in more than a dozen hospitals and a broad range of unit types, including intensive care, emergency, operating, inpatient, and others. She's published widely in the engineering, architecture, and medical journals on projects related to research-informed design of healthcare settings. Thanks, all three of you, for joining us today.
Thank you, Alan.
As I mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, Lighting and Nurses at Medical Surgical Units, Impact of Lighting Conditions on Nurses' Performance and Satisfaction, from the Health Environments Research and Design Journal. On today's call, we will have an active discussion about different key factors in your study. And if you would now please take it away.
Thank you. Hi, everyone. I'm Katie Hardy. Thank you very much for joining us today. I'm going to give you a quick introduction to the paper and give a little bit explanation about the methods, and then Jennifer and Erica will continue with the rest. So this was a research effort back in 2014. We conducted this research at Georgia Tech with the collaboration with Acuity Brands Lighting. Acuity Brands sponsored this project, and they helped us during the process as well. When we started this research, we were interested in knowing generally about the lighting environment for nurses in hospitals. So we conducted a literature review, and we learned that most of the studies in the literature are about the circadian disruptions from the nighttime lighting for night shift nurses, as well as the amount of light required for different tasks and how we can achieve a good level of lighting for visual acuity for nurses. But we were not able to capture many studies about the perception of nurses and preferences of nurses about the lighting, what they like, what they dislike, and how we can improve the environment for them. So we focused on study on understanding nurses' perception of lighting in medical surgical units. And because Acuity was interested in knowing more about the problem areas in medical surgical units, we focused on identifying these areas as well as finding out what the problems are and how we can approach them and fix them. The methods that we used for this study included both surveys and in-depth focus group discussion. For the survey, we designed an online questionnaire which was based on previous surveys and literature and what we found that might be interesting to know about the lighting. And we asked major nurses organizations to help us distribute the survey. And at the end, we got 393 responses from different nurses institutes. And we thought that this was a good number for us to start analyzing the data. After the survey, we also had a series of focus group discussion with nurses to understand more about the context of the lighting in their actual working environment. Based on the questions that we asked in the survey, we found out that most of the participants in our survey were nurses above 50 years old, and also the majority of them were working in day shift as opposed to night shift. But still, we got a good number of nurses in night shift that we were confident that we are able to get good statistical, meaningful data from our survey. We also looked at how many years they work in their current unit, and it turned out that more than 60% of the participants work in their unit for 6 and more years, which showed how familiar they were with their working environment. At the end of the survey, we asked participants whether or not they wanted to continue with focus group discussions, and at the end, we got 8 nurses participating in the focus group discussion. 4 of them were night shift, and 4 of them were day shift, and they were all women. Okay. About the terms of the research and data collection, as it's explained in the paper, we focused on 5 major locations on the medical surgical unit. So we thought that these 5 key locations were the most important spaces regarding nurses' task performance and the way that lighting would affect their work. So these 5 locations are centralized nurses stations, decentralized nurses stations, and patient bedside, patient bathroom, and corridors. And we had abbreviations for each of these locations that we used in the paper, and we are going to be using here in the slides again. So in our survey...
Sorry.
Go ahead.
Sorry, just a quick question here, clarification. For those who did the homework and read the paper ahead of time, they'll have noticed that you mentioned in the paper that perhaps some of the participants weren't correctly interpreting what you guys meant by the decentralized nursing stations. So could you just briefly go into what it was that you told them that you were asking about, and perhaps what some of the feedback was that made you think they may have been looking at some broader class of locations?
Okay. So when we asked a question about decentralized nurses station, we explained that these are usually the charting area outside the patient room that have chairs, and you can sit there and do your charting and other activities while observing the patient, something like that. Yeah. So after we specified these 5 locations, we organized our survey questions based on these 5 locations. We had a set up standard questions that we repeated for each of the locations, and then we were able to compare them together based on this structure. Our survey was designed in a 5-point Likert format, and we also included multiple choice questions, and we had questions about the overall satisfaction with the quantity and quality of lighting. We had questions about any possible issues that they could have with lighting, which was disturbing to them, like glare, flickering, or shadows from light resources. And then we had questions about controls specifically, because Acuity Brands was interested in knowing more about the lighting controls and how they could improve the lighting control design for the nurse environment. So we asked questions about access to lighting controls, importance of access, and ease of access to lighting controls. We also had open-ended questions at the end of the survey to give the nurses the opportunity to bring up any possible issues that they had. And as I mentioned before, we had demographic questions asking about the age, shift, and experience, and possible eye conditions that they might have. Then after we got the data from surveys, we decided to focus the interviews on 3 main questions about the lighting at decentralized nurses station, lighting at bedside, and the transition of lights from day to night for nurses for different spaces. So these were the areas that we felt that we needed to know more about. Okay. I'm going to hand it over to Jennifer for the findings and conclusions here.
Okay, and we're going to take it off speakerphone and talk straight into the phone for you all. Hello, thank you for joining us this afternoon. So I'm going to go over what we actually found in the study. And the biggest thing, the most significant thing we found was that across these different hospitals, because as Katie said, our sample came from all over the U.S. We didn't ask what hospital they were from, but we know that we at least had a lot of variety in that. But across even the variety of hospitals we talked to, we found that nurses converged in their opinions on what they thought about lighting in specific areas, that they were able to discern different areas and had different opinions and needs about the lighting in those spaces. And in particular, they were not satisfied with the lighting at the patient bedside or at the decentralized nursing station. And I'm going to go into a little more detail about that. So if we look at that satisfaction level, this was the question that we asked about overall satisfaction with lighting. And so for each of those 5 categories, again, that's the centralized nursing station, decentralized nursing station, and the patient bedside, patient bathroom, and the corridor. So we've highlighted there with the dashed red line the responses for the decentralized nurse station and the patient bedside. And you can see the light green and the red bars are the percentages of nurses who reported being satisfied with the lighting overall, not qualifying what we mean by satisfied with it. And we said those are the lowest numbers for any of the different areas, so they're pretty consistent across the sites. And they also have the highest amount of dissatisfaction. So over 50% of the nurses reported being dissatisfied with the light at the patient bedside, and over 40% at the decentralized nurses station. So we see that that light is clearly not meeting their needs. So then to kind of break that apart and understand what about the light is not satisfying them, what aspect of it, we also asked specifically about the quantity of lighting. So this chart, again, shows the percentages of nurses who responded that the light in that area was just right. So we see, again, lowest numbers coming from the decentralized nursing station and the patient bedside. And then we actually asked if they were if it wasn't just right, was it too much light or too little light? And specifically at the patient bedside, 64% of the nurses said that there was too little light at the patient bedside. It wasn't quite as bad at the decentralized nursing station. That was more of 43% of the nurses said it was too little light. But so what we're seeing is that for the most part, it's inadequacy of lighting and a lack of lighting, not enough lighting, that is causing the dissatisfaction in those areas. So we also asked, beyond just do you like it or do you not like it, we also asked what was important. We thought it was important to know which areas we should pay more attention to. So let's say you're Acuity or some other lighting manufacturer. What are the spaces where it really matters? Because just because a nurse isn't satisfied with it, if it's not an important area for lighting, then maybe that's not an area that they need to focus on. So we asked as well about importance, and not surprisingly, nurses said that the patient bedside was the place where lighting was most important, the quality of lighting was most important to them. And that makes sense since this is the place where they're doing their most important work. What's a little disconcerting is this is also the place where they were least satisfied with the lighting. And we saw from the focus groups, some of these comments that we shared here were about why they were dissatisfied or why it's important and why they're unhappy with the lighting there. I won't read these out; they're in the paper as well. But the message from these participants in the focus groups was that there's a real conflict at the bedside between the nurse's need to be able to see, particularly at night, and the patient's need to have a peaceful environment and to sleep. So they felt that they weren't able to have lighting that could meet both of those needs. So there were a lot of complaints and concerns about turning bright lights on in the middle of the night or even just in the evening, and that being disturbing to the patients, but yet the nurses needing that to be able to perform their work. So that gave us a little more insight into particularly what it is that needs to be fixed in that area. We also, as Katie mentioned, controls were something that was of interest to us. That was something that Acuity wanted to know about. So we asked about controls, which is something we hadn't seen in the other literature. And here we see a little bit different information. The dark green bar is the dark green portion of the bar is the percentage of nurses who reported having access to controls. And here we did not specify in this question whether or not that's just switches or if that was also dimmers, so any kind of control to the lighting. So here the lowest numbers of having access to controls were from the decentralized nursing station and in the corridor. And where we saw comments about that was a lot of times the light in the corridor can bleed into the patient room and cause too much brightness. And there tends to be a kind of a day setting and a night setting, but nobody owns that. Some of the things that we were hearing from the focus groups, nobody owns when to turn the lights on or who controls that lights. So in general, the nurses aren't even aware of the presence of switches because they don't feel like they have the ownership or responsibility for turning that on. So out in those shared spaces. And then we hypothesized, or wanted to see if it was true, that access to controls, being empowered and being able to control the lights might have some kind of correlation with satisfaction. Was that driving part of the satisfaction? And not surprisingly, it does. So we split this out in these two charts here. We split the nurses that had reported having access to controls and those who reported having no access to controls, dimmers or switches. So the darker green bars are the responses from the nurses who said they had controls, and the light green bars is from the nurses who said they had no lighting controls. And we see their satisfaction levels at both the patient bedside and the right one is the decentralized nursing station. And we see that the nurses with access to controls were more likely to report being satisfied with the lighting conditions overall than were the nurses, and the nurses without controls were more likely to report being dissatisfied. So, and this was statistically significant. We think we can conclude from this that having access to controls increases the satisfaction that nurses have. We also we asked a lot of questions around kind of intrinsic issues for the person, so their own personal qualities, their age, any eye pathologies, whether or not they wear glasses or not, how long they had worked in the unit, to see if any of that might be driving their perceptions and influencing satisfaction. And we looked at this a whole lot of different ways and tried to, crunch the numbers to see an influence, and we did not see any discernible trends in the influence here. That doesn't mean there's not an influence, but nothing that we saw overrode the trends that we reported earlier, that it was around the specific locations, that it was around something just happened to the screen, that it was more around that whether or not they had access to controls and whether or not where the location was and whether or not they had dimmers, but that eye pathologies and even age of nurse didn't seem to be driving anything. So also look to see kind of dig a little deeper into what kind of controls they have, and the nurses reported that it's more likely that they have access to a light switch than to have access to a light dimmer. So the dimmers, having a light dimmer is the lighter green bars on the left side chart, and so much fewer have that. The chart on the right shows, again, we asked nurses how important was it to have access to dimmers. And here you can see that by far the patient bedside is the location where they said that was extremely important. They're more likely to say it was extremely important to have access to dimmers at the bedside, but yet only 40% of the nurses reported having access to dimmers at the bedside. So there's a missed opportunity here. We did not ask specifically about patients, but we heard a lot about it in our focus groups, that not only is it that the nurses want better control at the patient bedside, but that they want there to be better controls for patients themselves, that it ends up being quite a burden on the nurses to have to come in and turn lights off. So, a nurse may come in the middle of the night or evening and turn a light on. As we know, they're very busy, they get distracted, something else calls their attention, and they might not turn that light off. Now the patient is there in bed, unable to control the lights over the overhead light, and they have to page the nurse to come back in and turn the lights off. So we heard that in these focus groups, and also in another project that we were working on, we heard doctors talking about how if they could just train nurses to turn the lights off. And again, maybe if you can train the nurses to turn the lights off, that's good, but even better, give patients control, and then it's a non-issue, and then patients can turn that light off when it's bothering them. So that was just an additional finding we had. So to go back to the overall finding, we learned what we feel we can conclude from this is that the quality and importance of lighting at different areas of the hospital does vary. Their nurses want and need different things out of lighting in different parts of the med-surg unit. And nurses in particular, those areas where it's really important to find better solutions are the patient bedside and the decentralized nursing station, which is really where the bulk of the nursing work is happening, and nurses don't feel like they're being served well right now by the lighting that's in the hospital. So now I am going to turn it over to Erica, who is going to tell us about some of the implications for design and limitations to our study, if there are any.
There are always limitations.
Thank you.
So I will also switch over off of speakerphone here for this part so that hopefully everyone can hear me. And today I'm going to speak for just a few minutes about the design implications and limitations, really to help stimulate our thinking for the upcoming discussion period of today's call, which we're very excited for. So thinking about some of the design implications, here we're listing some of the takeaways from this particular research project. So for example, based on what the nurses were telling us in these surveys, there may need to be some rethinking of lighting design at problematic locations. Specifically in this study, we found the decentralized nurse station and bedside, as Jennifer mentioned. Also thinking about the intuitiveness and how distributed our control systems are, and that they incorporate dimming for both nurses and patients. Providing task lighting for the nurses and adjustability at decentralized nurses stations was also something that popped up repeatedly. Now, as many of the callers probably know, a lot of these things are already incorporated into design to some extent, but clearly if these nurses are still complaining about these things, we're not seeing this applied in all facilities and all locations. The good news also is that increasingly we're seeing a lot of these kinds of ideas incorporated into the recent iterations of the design guidelines, such as the IES guidelines, which were, I think, updated last year. So these results from this research should hopefully provide additional support for those guidelines, and hopefully if the guidelines are really implemented, we might see less complaints in some of the newer facilities. So here we show an example of lighting design in a patient room, just a typical patient room here. And I'll note that these are renderings provided to us by HDR. So HDR wasn't specifically involved in the research project that we're presenting on today, but since Katie is currently working at HDR as a design analyst on the data-driven design team, they were gracious enough to provide us with some of these examples. So in the first photo on the left there, you can see a view towards the visitor area and the window, and these are at night to fully show the effect of the illuminance. In the second photo, you can see the view towards the corridor door. And the idea here in these photos and some of the ones we're going to look at in a second is to take a layered lighting approach. So here we see the floor plan for this example patient room. And you can see yellow highlighting the control stations at the door, the head wall, and the bedside. And as you see in the pictures, the close-ups of the controls, they do give a variety of these layered lighting options, so ranging from full on or full off to a night light setting, to exam setting, and these do provide dimmers. So again, the approach here is to give the staff, the patients, and also the visitors a good degree of controllability of their lighting environment. So now let's just step through some of the lighting modes, again, to stimulate our discussion today. So of course, these are rendered when it's dark outside so we can fully depict the artificial sources. And for example, in this first one here, you can see the little green dot on the control, so we're showing the rest mode with the partial lighting on. Here's another example. This one is showing general on, which of course is going to provide our higher luminance levels. Our third one here is going to show the exam lighting mode, which of course is going to allow for the patient care activities. And the next one we see here is the night lighting, which of course is the darkest mode to promote sleep, but still provide some lighting for safety in navigating the room. Here we see another example of layered lighting in a patient room, and this time we're looking at photos, and these are provided to us by Acuity. So these photos are a little different because they're in the daytime, which lets us look a bit how the layers of light interplay with the the natural light that we have coming through the windows. So finally, today we'll discuss some of the limitations of our study. So this was a purely survey-based study. We did not measure the actual lighting conditions, such as the levels of illuminance at different locations or in a variety of units. And that was really done because our goal was to gather perception from a very broad range of nurses. So we had hundreds of respondents, and we wanted that, but it simply wasn't in the scope to visit the respondents' units, although that would be perhaps an interesting study down the road. We also did not specifically ask nurses about light sources, such as the types of luminaires or the amount of natural versus artificial light. And the decision not to ask them a lot of specific questions about the light sources was partially because we thought that they could perhaps have limited understanding of the different possibilities of lighting, both within their current units and as perhaps options for future design. And also, we just wanted to keep the survey at a reasonable length, so we were limited in how much we could ask at their time. But of course, all of these things could be expanded on in future research, and of course some other researchers have been looking at these things as well.
Thanks very much for that presentation. Before we get on to the Q&A session, I'd like to make a couple of announcements. This event is brought to you by the Center for Health Design. Thanks again to the Herd Journal for providing access to the articles we typically review, and special thanks to today's sponsors, Steelcase Health and American Ultraviolet. Please be sure to join us on August 16th for the next Evidence-Based Design Journal Club featuring Stephanie Schurzbuch and Sophia Skemp of BWBR as they discuss their study, Does Space Matter? An exploratory study for a child's adolescent mental health inpatient unit. And now it's your turn to ask questions of the author. Please feel free to type in any questions you may have and we will try to answer them. The first question coming up in the main chat here is one that I also had, is I didn't read anything on nurses' perceptions of the color of light. Do you think this could have impacted nurses' responses?
I think color could impact it. It's a very hard thing, as Erica was saying, to ask people about the color of light. I mean, we would have had to ask them that. And in fact, based on the focus groups, I didn't see that nurses, I guess that would be asking nurses to make determinations about lighting that's really kind of outside their area of expertise. Not saying they're not smart enough to talk about light, but even with talking about dimmers and what kind of light options were available, they seem to really only know what they have in their unit. And, we would start getting this crosstalk in the focus groups where a nurse from one hospital would be talking about what they have and a nurse at the other hospital would be going, oh, wow, that's amazing. I didn't know we could do that, or that, you could have that, or we're not allowed to do this. So I wouldn't have put a lot of stock in their input on color, because I wouldn't have been able to feel it was a consistently defined. Is that, Erica, Katie, do you agree with that?
Yeah, I agree. I mean, I think it would have, certainly there are ways to ask about color, but it would have lengthened the survey to an extent that we weren't comfortable with at that point. But certainly any of the physical measures like CRI or, illuminance levels, those kinds of things, anytime you can ask questions that are relevant to those is helpful. So I think that could certainly be something to look at further.
Great. Another question we have here from, sorry, it scrolled past it, from Ben Devaney is, how can lighting be improved at decentralized nurse stations? I know this isn't an interventional study where you're going out and trying out new things and seeing if they work, but maybe based on the qualitative feedback that you got?
Yes, we were actually able to get some insights about this question from the survey, because we found out that there are two major issues at decentralized nurse stations. One of them was access to lighting controls and specifically dimmers, because it's really a common practice maybe right now to include controls at patient bedside, but it's not something that we have available everywhere for decentralized nurse stations. So that's something that would add a lot to the quality of their working environment, because then they will be able to adjust it to the level of that they need for different tasks. Maybe it's just writing down, or maybe it's just sitting and observing the patient. So they might be able to get better satisfaction if you add the controls to the decentralized nurse stations. The other thing that we found at decentralized nurse station was the issue of the shadowing, because of the level of lights that were low at decentralized nurse station, and there were many complaints about the shadowing. So that's another thing to have in mind and come up with the solutions to address.
Nurses also mentioned wanting lighted keyboards, and I think kind of one of the points about the definition of what the decentralized nursing station is. sometimes, I think they were responding about a charting station or a computer on wheels. So they might be thinking of that kind of as their decentralized nursing station. So they also said, having a keyboard that's lit up could help, that they could see that to be able to chart, or having really focused task lighting. So they felt like they didn't need high illumination overall, but they might need very targeted lights.
Great. We have a couple questions about how you chose the number and constituency of the participants in your focus group.
I can respond to that. We sent out, I think Katie said there were, I think 100 people after the survey had said they were willing to participate in focus groups. We wanted to make it so their responses were anonymous, so we had them directed to another website. And out of all of those folks who we offered, I don't remember what the compensation was, but we offered a gift card to participate, and we only ended up with 8 people that called in and completed the survey. So they were self-chosen. So we did do them at different times of day, so we could try to get day and night shift. But so self-selected as nurses who were either A, really interested in talking about lighting, or B, really interested in $25 or $50 gift card to Amazon or Starbucks. So they were self-selected. And we didn't, even those nurses that did the focus group, we did not ask them about their hospital, so we don't know. We only asked what shift they worked on.
Right, yeah. There were a couple questions that we've gotten about that, details about the hospital, how old the hospital is, or whether it's the normal lighting that they're talking about, but that's not within the scope of the study because you're trying to preserve the participants' anonymity. Is that correct?
Correct. We asked them, I think we only asked them what shift. I don't think we even asked them how long they had been in their unit.
No.
Okay. In the focus groups and the maybe even the open feedback section of the survey, did you get any input on what works well? A lot of the focus of what we've been talking about is sort of the trouble that they've run into. And, having worked a lot with nurses, they're always really happy to share both of those sides with me. So is there anything that they had to say about what works well for them?
I think I remember some quotes from the focus group discussion about those nurses who had lighting control at a patient bedside, and they were really happy that they were able to go in and adjust the light to the level that they want. But even those people had some comments about the level to that they could adjust the lighting. So there are already many technologies about how we can control the lighting at different locations, but I think something that really could be improved is to look at the range of the lighting. As I mentioned before, the color of the lighting, the intensity of light, and understand really among all those products available out there, which one is working better and what is the good lighting for each different task.
Some of the nurses reported having flashlights, and they really liked that. And then there was always a debate on the focus group calls of nurses who said they weren't allowed, infection control didn't allow them to carry flashlights. So that was, maybe there's a way to solve that that's not a personal carrying of a flashlight, but clearly it's indicating a need, that they need this point source of light.
Goes back to Florence Nightingale, the lady with the lamp.
That's right. You can give them all lanterns.
Yeah.
Exactly. Craig Zimring asks, are the design... Oh, scrolling while I'm reading.
We don't take questions.
Are the design implications you discussed available with current technologies, or will these require new applications?
I could start on that one. So there are a lot of really neat and exciting new products out there that have been tried out to some extent. So I would say the answer is a little bit of both. I think there's some new technologies that are out there. I've seen some neat bedside lighting options where they have, a reading lamp integrated, and it's a really narrow beam width to avoid disruption to other people. I recently saw some, and again, I haven't seen the research to see how well these work, but I've seen some, lighting options that mimic windows that are backlit for interior spaces that can't actually have windows to begin with, and that they use some LED technologies to help mimic the color and those kinds of things. So I think there's new and exciting products out there. I think they're being used to some extent, but I think it would be great to see some research to see how well these are working for staff and for patients, and what their effects are. I don't know if Jennifer.
Absolutely. Elizabeth asks, can you give us an idea of how many hours in total this study took all of you?
I laugh because that's a good question. We might not want to know the answer to, Elizabeth.
Yeah, right. Yeah, which part? The survey didn't take that long. I think it was the statistics that took longer, right, Katie?
Yeah, because when the data that we got out of the survey was in 5-point scale. So it's a little bit different from when you got normal distribution. So we had to run different type of statistics tests on the data because the data was non-parametric. So it took more time that the common methods of statistical analysis usually take. I would say maybe 2 months. Mm-hmm. Running the data analysis and then being able to interpret the data.
I think we worked on it for around 6 months or a year total. Is that right, you guys? Mm-hmm. Something like that is my recollection.
Yeah.
And Ellen asks if you have any plans for follow-up studies on this topic. Mm-hmm. Sounds like yes.
Well, Katie and I have a paper out for, we have a paper out for review on light and sleep, which is a slightly different topic. And then, Katie, you have some other research of your own?
Yes. So some thing that we couldn't capture from this survey was the implication of daylight as opposed to artificial light. So recently I've been involved in daylight studies about the working environment of nurses at a hospital with HDR, and that's a project in process, but we learned a lot about how daylight would bring benefits to the nurses regarding performance and reduced stress and absenteeism and all kinds of good outcomes. So that's something that I would definitely want to work more on.
And I can also add that that I'm working on a study here in Nebraska, which is a multimodal study. So we're looking at the interplay of light, noise, and air quality, and how the three are perceived by staff in relationship to each other. And that's a collaborative study with HDR.
Yeah, that's so much exciting stuff in the pipeline. I look forward to reading about all of that. In the focus groups and open-ended questions, did nurses bring up any other areas where lighting is a challenge? For instance, supply closets, medication preparation areas, things like that?
We did not hear that. I mean, what I heard that maybe went a little off what we were focused on goes back to this issue of the flashlights, was specifically for exams, doing patient exams, that even the exam light wasn't always adequate for causing shadows, particularly for catheters. But it seemed like, and that's maybe where some of the previous research had been done around kind of medication dispensing in pharmacy and how much light is needed for that. But we didn't hear them bringing that up.
Okay. I have a question from Karen Murphy. I'm not sure if I understand it correctly. It's, who is reviewing? Have you asked the IES or IALD?
I think that's about our paper. I would assume that's about the paper that I said Katie and I have out for review, and it is, Katie, do you get...
I don't think we can say the name of the journal yet.
do that. Right. It's still up for review.
Yeah.
But I will say, while the subject of IES has been brought up, that the next year IES is having their symposium in Atlanta, and part of the reason to come to Atlanta is so that they can have a tour of the Cemtegrate Design Lab. So I'm sure that applies to some of the folks on the call today, that they'll want to come to the IES symposium in Atlanta and then come to our lab and see it.
Very cool. What solutions do you see for the problem of the hallway light bleeding into those patient rooms at night? That seems like, with the limited space available in patient rooms already, it's not like you're going to put a vestibule in there probably. What can hospitals do about that? I know it's beyond the scope of your study, but probably something that you've thought about.
Certainly. So lower lighting levels at nighttime, less direct lighting, so more up lighting, so light that washes the walls so that it's not going to splash down into the room. But I think the biggest thing that seemed to be kind of an aha to the nurses talking to us was this idea that someone either owns changing the lighting or maybe that becomes automatic. So it's one less thing that nurses have to think about whether or not, lights come on or lights come off. Go down, so having a nighttime mode, but also perhaps, and it's just speculation, that illumination levels in general in the hallways are bigger than they need to be, because there's really not a lot that's happening in the hallways. It's, you're just trying to get from one place to the next. If you need to be doing a task like reading a medication or a bottle, that's at a specific focused area where you should have lighting focused for that, right? You should have better lighting for that, but the general illumination shouldn't be so bright.
Very cool. We have a question from Sue Minachuk, and she's asking, can you say more about the lab, or LAB? I'm not sure. It's all in caps.
Sure.
Not sure
so
what exactly it is.
The Design Lab. So the Cemtegrate Design Lab is a 5,000 square foot space here where I'm sitting right now in the College of Design at Georgia Tech, and it's where Eric and Katie were when we were collaborating, so this is where it all started. So we have a lab here where we're able to mock up healthcare spaces and do tests. So we have an inpatient room that we built with support from Philips, installing their dynamic lighting system, the HealWell system. So we had that installed. It's not operational at this point. We also are running some tests at the moment on donning and doffing for Ebola care treatment. So we have an area set up that's like an ICU room where healthcare workers can come and can train putting on and taking off their PPE, their personal protective equipment, and we can watch that to see what impacts the built environment has on it. So we do a range of studies and tests here. And that's our lab.
That is super cool.
We give lots of tours, and we have great parties and receptions.
Hear that, everyone? Free food. Just get to Atlanta.
If we find a sponsor for the free food. So, yes. And I should say, Craig Zimmering he's the director, and he has a Healthcare Design in the Future class that he does every fall, and they have kind of their open house showcase at the end of the semester here in the lab. So folks here in the Atlanta area may be familiar with that, and if they're not, you should look us up and come to that in early December.
Great. In the paper, you mentioned glare and shadows as particular lighting challenges for the nurses. Can you tell us a bit more about the qualitative insights that they gave you into those problems?
Yes. So glare only came out as a significant issue in centralized nurses station. And based on the questions that we asked from nurses, we understood that it's usually because centralized nurses stations don't get that much natural light. There are usually big light sources, like a big ceiling light. So that's something that causes glare for them, or wall-mounted lighting, which bring those kinds of glare issues. But at other locations that we had light issues, such as decentralized nurses stations and patient bedside, we had the lighting, we had the shadow issue, and that was partly because the level of the light, which was low at this location, and also because the location of the light source, which could cause the shadow on different surfaces.
Very cool. And that's it for my questions. We did have one more question here, and that was how you evaluated the performance aspect of the nurses, but of course you weren't evaluating the performance aspects of the nurses in this study. Did they talk about, however, in the focus groups, the ways in which lighting challenges impacted their performance and the things that they were worried about as a result of that?
I think part of that came up in the focus group discussion, and we didn't specifically ask any question about the performance, but as they explained, we learned that they spend a lot of time at patient bedside, taking care of the patient during the exam. And of course, they spend a lot of time at the decentralized station, watching the patient or doing the paperwork and charting. So those are the locations that they spend most of their day doing their tasks. And those are the most problematic locations as well. So you could imagine how these lighting problems would interfere their performance.
Sure. Craig Zimmering asks, you focus on nurses' perceptions of lighting for their work. Did anything come up in the focus group about lighting preferences for patients? I know you did touch on that. They're being able to sleep, not being sprung awake. Anything else in that realm?
That was the big issue, was that patients were startled by the light. They didn't like how suddenly it came on. And that nurses felt really kind of torn between disturbing the patients and doing their work, and that at the end of the day, they kind of their default was that they had to get their job done, so they would turn the lights on. So, and patients wanting to have the ability to control the lights themselves. And then I saw a question here about how we contacted nurses. We distributed the survey through, I don't remember the names, through several different organizations. So I don't know kind of the population that actually was asked to fill out the survey or had the opportunity to fill it out, but we had it distributed by nursing organizations, and then people chose to participate or not.
One of them was Nurses Institute for Health Design. So they have a good website that they can go on, and we were able to connect them to their website.
Well, we're coming up on the end of the hour. Are there any last questions from the audience? Any last insights you three would like to share with us?
Speaking about patients, we do think that it's very important that patients have proper lighting at night so that they're not disturbed, and that we pay attention to actually having an absence of light at night. So that's, again, another piece of work that Katie and I did and published on inpatient environments for sleep, and that light was one of the main disruptors of sleep.
Absolutely. Question from Jennifer Berryman. It seems that a lighting control system like those that are used in high-end residential and hospitality environments could solve many of these issues. Settings are saved as scenes, and the conditions change, i.e. night versus day. They can be implemented to provide the best quality of light. The lighting control systems would not prohibit task lighting where needed. There's actually something very similar in this room that I'm in. I don't have fine control of the lights, but I can press one of 5 different settings, and it works like that. I know that was it seemed like part of the layered light approach that you talked about. Perhaps would a more nuanced version of that be helpful for the nighttime nurse entry scenario?
Yeah, I think so.
Absolutely.
And I think we're seeing a lot of crossover between the hospitality industry and their design for experience, and that's becoming more of a thing in hospitals. Experience, right? Not just treating symptoms. So I think it's a great sector to look into, and I think having these types of scenes, I think the more you can have things are to an extent preset but still allow for individual controllability is probably the right direction.
And Caitlin here talking about future research mentions that the conclusion mentions that you'll be looking at measuring the environment. I'm very interested in seeing quantifiable amounts for inadequate versus adequate light levels. So perhaps somebody who would like to use or cite your work, if you can build that into your next research papers.
Yes, we're more than happy to share our survey.
Yep. I want to answer a question that I think is probably out there, or maybe is implied by Jennifer Berryman's question, is kind of, the technology exists and we're doing it in other places, why not in hospitals? And I think, don't have proof, but I think that the reason is budgets. So it's just a matter of getting controls put in there. I'm sure that the lighting companies have technologies available and offer that to architects and designers, but when it comes down to it, it's not being prioritized. It may be valued engineered out. So, I hope that our research kind of helps put a finer point on that there is a value to it, and, it's hard to put a number to what that value is, but maybe go ahead and make that investment in the additional amount of money to have controls that allow for this flexibility. So take this to the owners and say, here's why you shouldn't VE this control system, because you see it is important.
Fantastic. Well, on that note, thank you very much, Katara, Jennifer, and Erica, for this interesting and thoughtful look at how lighting conditions can impact nurses' performance and satisfaction. This concludes our event. We'll leave the webinar open for another 30 minutes so you can download the EDAC and AIA CEU forms. Thank you again for joining us. Thank you so much to the three of you for presenting, and have a great day, everyone.